Care Consortium this year. I'm your MC for this virtual conference. Before we really dive into today's event, let's review a few Zoom tips to make this the best experience possible for you. There is a chat function in the Zoom menu bar at the bottom of your screen, and you can use chat to introduce yourself to other attendees, to share resources that you feel others would find helpful. If you do want to type something to share, Zoom does default to sending it to just the panelists. So if it's something you'd like everyone to see, please change it in the drop-down to say all panelists and attendees. And some people find the chat to be a little bit distracting while the session is happening live. So feel free to close out the chat. You don't have to follow what's going on in there. We may just share a few helpful links related to some of the things we'll be discussing in the session, and others may be sharing resources or introducing themselves. There is also a Q&A button right down there next to chat, and this is where you want to type in your questions for today's speaker. It's hard for us to find all of those questions if they get put into the chat, so questions for the speaker should go over in that Q&A box. And if you'd like to adjust your screen layout today, you can go up to Zoom, the top right corner, and change the view. You can have speaker view up if you'd like to see the speaker front and center, or if you change to gallery view, you have kind of like the Brady Bunch going on there with a bunch of different faces on the screen. So go ahead and adjust the settings to what feels right for you. This year's conference theme is Grow with the Flow. Learn, adapt, and thrive. This theme reflects our opportunities to grow and evolve as caregivers while being flexible enough to go with the flow during uncertain times. So each day this week, we are bringing you daily opportunities to learn together, to adapt with the new information that we're taking in, and to really thrive, to build our confidence, to build our hope, to build that box of tools that are available to us as caregivers. We had fabulous presentations on Monday and Tuesday, and today promises to be extremely informative as well. The Northern Virginia Dementia Care Consortium Caregivers Conference is organized each year by a committee of volunteer professionals who you can view there on your screen. And these professionals work all year long to bring you this high quality education event. Also, thanks to Steve Gurney of Positive Aging Sourcebook for being our tech guru and making all this happen behind the scenes. And now I'd like to invite one of my NVDCC colleagues, Leslie, in for a special message for Veterans Day.
Thank you all for being here today. As you know, we typically meet on Veterans Day in person, and although today we're not able to be together in the same room, we're fortunate that we can hear from some incredible presenters from the safety of our homes and our offices. Veterans Day is a time to honor those who have served our country and who have fought for our freedom. I am the daughter of a Jewish Army veteran who liberated concentration camps during World War II. And when I think of my father who braved things we can only imagine, I am eternally grateful. We all have similar stories and feelings for those who we know and love who have served our country. Today, we say thank you to those who have served and to those who have supported the men and women who have protected us. We thank you for your courage, we thank you for your sacrifice, and we thank you for answering the call to protect our great nation. Enjoy the conference.
Thank you so much, Leslie, and thank you to all of our veterans and families of veterans who are with us today. We are grateful also to our conference sponsors for helping to make this event possible for caregivers in Northern Virginia and beyond. And today's conference sponsor is Goodwin House Incorporated. So I'd like to invite Jackie Barbarito to join us to share a few words about Goodwin House, and then we'll see a short video. Hi, Jackie.
Hi, Lindsay. Thank you. Good morning, everyone. Goodwin House is a mission-driven, non-for-profit organization committed to exceptional service and personalized care. Our family of services includes 2 senior life plan communities, an innovative continuing care at home membership program, healthcare services, and Goodwin House Foundation, which serves our community. Goodwin House has been a sponsor of the Northern Virginia Dementia Care Consortium for many years and we are happy to continue our support. Goodwin House's Dementia Advanced team was recognized by Leading Age Virginia as the Dementia Friends Champion of the Year Award for our efforts in dementia education, awareness, and programming. We are now pleased to share our acceptance video with you all and honored to be a part of today. Thank you.
The Alzheimer's Association estimates that 150,000 Virginians are living with some form of dementia. This number is expected to rise to 190,000 by 2025. With statistics like these, we can all expect to feel the impact of dementia in ways both big and small. Now more than ever, we must come together to focus on how to provide the best care and support for those living with dementia. Not just those with a diagnosis, but their families, their friends, and their communities. Dementia can be overwhelming, yet together we can make living with it better for everyone. When Leading Age Virginia called members to support Virginia's Dementia State Plan, Goodwin House took aim at Goal 3, increase awareness and create dementia-specific training. As part of our strategic plan in 2018, we set a goal to promote and facilitate a higher quality of life for people with dementia. And to reach that goal, we created our Dementia Advanced team to lead this effort. This interdisciplinary group seeks knowledge, programs, and services that promote care and understanding for individuals with dementia and the people who care for them. In less than 18 months, our Dementia Advanced team has achieved many milestones. All members of the team are certified dementia champions. There are 12 of us. 100% of Goodwin House staff members are dementia friends. There are more than 900 of us. More than 60 residents, staff, and their families attended the 2019 National Walk to End Alzheimer's in Washington, D.C. We've trained more than 1,000 dementia friends outside of Goodwin House, from police officers and first responders to members of the clergy and church volunteers. We collaborated with other local community partners and government officials to establish 3 dementia-friendly communities in Northern Virginia: Alexandria, Arlington, and Fairfax. Thank you, Leading Age Virginia, for honoring the Goodwin House Dementia Advanced team with the Dementia Friends Champion of the Year Award. We are truly grateful.
Thank you to Goodwin House for being a sponsor for this Caregivers Conference. We appreciate you and all of the hard work that you do in the community. And now let's share just a few housekeeping tips. Some of this will be very familiar to those of you who've joined us the last 2 days. Our conference schedule, we meet every morning this week from 10 until noon with a different session each day. So I hope that you can join us. You can view the previous day's sessions if you go to nvdcc.com and go over to our schedule page. We do record each day's session, and the recording will be up by the end of the day. You can also find the handouts for each day's session on the very same page. So follow the link that we're dropping into the chat. You don't have to furiously take notes. You can listen in, you can really absorb what the speaker is saying, and then have those handouts for your reference later on. And if you are a professional attendee and you wish to apply to George Mason University for 1 continuing education credit, a unit, you must attend all conference sessions, and we will provide the link to that CEU at the end of the week. The cost is $50 and it's payable to George Mason University. One of the most valuable aspects of our Caregivers Conference is the exhibit hall, and rather than racing around the room during breaks, this year you have our virtual exhibit hall available to you 24 hours a day for the entire month of November that you can take a look at from the comfort of your own home or office. So feel free to make your way around that exhibit hall. Click on the different tables. You'll see the sponsors at the bottom, other tables all the way around, and explore some of those resources that might be helpful to you, to your loved one, or to a friend. And now I'd like to bring in my consortium colleague, Amber, who will introduce today's session and speaker. Welcome, Amber.
Hi, good morning. Today's session, sorry about that. Good morning. Today's session is titled, "If It's Not Alzheimer's Disease, What Is It? Getting a Diagnosis and Care." And our speaker is Dr. Chiadi Onyike. He is director of the Frontotemporal Dementias program at Johns Hopkins, and he specializes in neuropsychology, and his practice focuses on conditions that develop in midlife or earlier, including frontotemporal dementias, young-onset Alzheimer's disease, and other atypical conditions that cause cognitive and behavioral impairment and dementia. And we're really grateful that Dr. Onyike could join us today. So please join me in welcoming Dr. Onyike.
So, thank you, Amber. And I'd like to say thank you to Lindsay and to everyone involved in the organization of this Dementia Care Conference. I see that it's in the 34th year, and that's a great credit to the consortium, to the conference organizers, to the consortium behind this conference. And thank you all, everyone who's come in to participate today. I'm going to share my screen right now. I'll be talking, you've seen the title, and what I will be doing is basically talking about the kinds of syndromes that we encounter. I'll tell you a bit about the natural history, and what we mean by natural history is how these conditions develop over time. So people are fine, and then they develop symptoms, and how does that continue to go forward? And then we'll talk, and that will lead us into diagnostic rules and procedures, and how we actually go about making the diagnosis, how we go about confirming that diagnosis, how we go about estimating the severity of the problem, and then we'll talk about what we do for care, for treatment, for care. And I will also try to give you some insights as to what we're doing to upgrade, if you will, the kinds of treatments that we have today. On this slide, you can also see my disclosures, and this is a long way, or you can see all the acronyms and such. It's a way of telling you that I'm unbiased, or claiming that I'm unbiased. Basically, I've been an investigator in NIH and studies and foundation studies. So the ADDF stands for the Alzheimer's Disease Drug Discovery Foundation. And these are studies of neurodegenerative diseases. The SCA, spinocerebellar ataxias, are also neurodegenerative diseases, some of which cause dementia. And as part of the work I've done over the years, that has also included not just NIH-sponsored and industry-sponsored clinical trials, but also clinical trials sponsored by pharmaceutical companies. A number of years ago, I was involved in the US-wide memantine trial. The LNTM trial was an international study. And we've also been more recently involved in studies trying to look at how measurements. So when we measure the severity at the bedside, we also want to understand how those measurements change over time, because that's how we test drugs, newly developed drugs, to see if they're effective when when people make the presentations to the FDA. And there is a new trial that's some of the latest trials, like the AL001, are focused on hereditary frontotemporal dementia. And I will be talking a bit about what the term hereditary means. What does it mean to have a family history? What does it mean to have a hereditary dementia? When we prescribe medicines for frontotemporal dementia, or for Alzheimer's disease, or for any other condition, very often we're prescribing them in ways that are not on the label, on the drug label as approved by the FDA. And that's because the FDA's labeling really is a way of establishing that the drug is at least effective for something, and that it's safe, or safe enough to be using. But many medicines that are prescribed by doctors have uses beyond the initial use that got them the FDA approval. And in the case of treating people who have dementia for the various problems they have, most of the prescribing is based on creative use of what already exists. Now, many of you will be familiar with Alzheimer's disease, which, very often when people talk about dementia, they're talking about memory. And you'll have, for example, people talk about strengthening your memory. People talk about a memory clinic. And so all of this comes from the work done by Alois Alzheimer, who you see on your left. And in the 1890s, he became interested in neurodegenerative diseases, and he met Auguste Deter, the lady on your right. She was 51 at the time. She had forgetfulness, which was the most prominent part of the problem she had. She also had a lot of behavioral disturbances, anxiety, agitation, delusions. She forgot things very quickly. So she had very poor short-term memory. She was very confused. She had poor knowledge of who she was, who her relatives were. She didn't know where she was. She had trouble naming things. And she also didn't recognize certain common objects. He continued to see her and recorded the progress of things. And then when she died in 1906, he examined her brain. So now I should have warned you before I got to this, but for those of you who will have trouble looking at a brain, feel free to turn away. I will have one more brain slide and you can turn away again. I'll try to warn you beforehand. The pathological this is what Alzheimer described. Now these are not slides of Alzheimer's own work. Let's start with this slide here, the panel here. I hope you can see the arrow. I'll move it to the white background so you can see where I am. So if you look at your top left, what you see is a brain with a lot of spaces. So we call these gyri. And we call these spaces sulci. And the way we know that neurodegeneration is taking place is that the sulci are wider because the gyri are shrinking. And this was the first basic contribution Alzheimer made when he examined this Deter's brain. The second major contribution was to describe what we now know today as plaques and tangles. So the plaques, as you can see here, for example, where the arrow is, and right here, this loosely organized mass here, are basically deposits of what we call amyloid protein. And I want you to remember that word amyloid because we'll come back to it. These are basically deposits that are outside of the brain cells, but they're in the brain. So it would be like something is gunking up the works, so to speak. Here you have what is called a tangle. This is right here. This is essentially a dead brain cell, but it's the stain here. The stain that's used basically allows us to see what we call the tangle, which is all the black inside the cell. And that's made up of tau protein. So that's another word I want you to remember, tau, T-A-U. Together, plaques and tangles, as shown here, you can see a lot of plaques and a lot of tangles. They look here like tadpoles. These things together are what constitute Alzheimer's disease. Now, today, that was what Alzheimer contributed, but today we now know, one of the first things he contributed, I should say, but today we now know that there are many other conditions that can cause loss of thinking skills and loss of behavioral skills and cause people to have other things like anxiety and agitation and hallucinations and so on. Together, we call these things dementia. So I've often had people come to the clinic, and perhaps some of you have had these questions too. I've asked these questions of your doctors. What is the difference between dementia and Alzheimer's disease? Well, dementia basically means a person who suffered a loss of their thinking skills. And we can think of some of those thinking skills as memory. So the ability to remember things that you've just discussed or you've just decided that you're planning to do. Reasoning, that would be the ability to think things through. Social awareness, you come into an environment and you can sense whether you're welcome or whether you're not, or you can sense how you're expected to behave. You know how to respond to a gesture. These are all aspects of social awareness. Judgment has to do with the ability to weigh things, whether it's evaluative judgment, how much what's a better value. If you're in the store and you're trying to decide what to buy, you may make a judgment about what's the higher priority or what's a better value. Orientation is more complex in the sense that the term refers to multiple things. It refers firstly to time. And many of you who've been to memory clinics will have had people ask, tell me the date, tell me the year, tell me the season. And so we are asking questions about orientation to calendar time. You can also think of time in terms of in relation to the passage of time. So when you say to someone, I'll be back in an hour, they're estimating they have to be able to estimate what that means in terms of when they should anticipate your arrival. Or you might say, the show comes on at 10 o'clock. And so that's about the hours. It's morning, that's about time of day. Now, orientation also refers to where you are in space. So you're in a restaurant and you go to the restroom, or your loved one goes to the restroom, and they have to be able to find their way back to that table. So that's navigation of space. So you have to be oriented. You have to have an orientation to where you are in relation to where you're going or want to go. You also can have, and then the next thing would be the next major thing is speech, the ability to understand what people are saying, the ability to communicate what people will understand, the ability to engage in an exchange, in discourse. And we have one thing that I didn't put on this list, which I would like to mention as well, is praxis. And praxis has to do with the ability to basically execute actions that are sequenced. So when, for example, you get in the car to drive, you don't consciously think about putting the key in the ignition, changing the gear and all of that, you just go. You get on a bicycle and you go. You're handed a fork, you know what to do with it. You're handed a knife, you know what to do with it. You have a screwdriver, you know how to use it. So these are skills that are ingrained, that have been learned. And praxis refers to the ability to execute learned skills or to execute sequences of actions to do a task. So as you can see, there are many things skills that we have that we, in a sense, could take for granted most of us take for granted as we go through life, until we get to a time in life where these things become more noticeable to us or more important in our lives. Many diseases can affect them, and the patterns in which they do this differ. So as I've already illustrated, Alzheimer's disease is classically a memory problem. The most prominent aspect of Alzheimer's disease tends to be memory impairment, forgetting. It often is accompanied by confusion and disorientation. Frontotemporal dementia, on the other hand, is typically characterized by misbehavior. And when I say misbehavior, we're not referring to agitation or to irritability. We're referring to more perplexing behavior. So a person is voiding in public who previously would not have done such. A person is reaching into someone else's plate to take food. Or you're in the middle of conversation and you just walk away. So these are basically people who have lost their manners, so to speak. They are also, it's not just their actions, but also their capacity to engage with people emotionally. So they often come across as aloof, as indifferent, and they are not able to communicate properly. Often it's because there's a breakdown in their capacity of language, and sometimes that's the main problem. But also it's because they don't have an understanding of discourse, of the exchange, the conversational exchange. And so they become childlike in the conversational exchange. And if you look from your left on this slide, starting here and go all the way across, you can see that the menu, if you will, of symptoms that describe these various class categories of dementia are different. And when we say someone has Alzheimer's disease, we're saying they have not just that syndrome of forgetting with confusion and disorientation, but we're also saying that they have plaques and tangles in the brain. What are we saying, for example, if we then say that they have frontotemporal dementia? We're saying they have mainly problems with behavior and problems with use of language. And we're not saying that they have plaques and tangles in the brain. We're saying something else. Let's talk about a case of frontotemporal dementia here. So this was a 61-year-old former dental hygienist that I met a couple of years ago. And at the time I met her, the complaint was that she had had gradual changes in her judgment. She had become aloof. She had poor self-control, and she had become rude. And what they meant by rude was that she was so jocularity refers to unduly cheerful, playful, even when people are trying to be serious. She was laughing when she shouldn't be, and over trivial things. She talked in ways that were insensitive. She for example, told a vagrant that he had bad teeth. She danced exuberantly in public with little provocation. And she had a childlike repetitiousness. So what is an example of childlike repetitiousness? Perhaps many of you will know that, most of you probably know that children at a certain age often repeat the same question. When are we going to the store? Are we going to the store now? Can we go now? And this is the sort of thing she was doing. She also engaged in compulsive grocery shopping. So she was going to the grocery store, buying groceries, and then going back and repeating the thing and buying the same groceries again and again and again. She also was having trouble at work. She couldn't learn the new office technology. She had trouble finding words when she was conversing. Now, interestingly, her orientation to time and to space were fine. And this is typical of frontotemporal dementia, that they are able to keep track of time and they're able to navigate the environment, and that can persist until a very late stage. And she didn't have any trouble with arithmetic, and that's also typical of frontotemporal dementias. But she was making mistakes at work and at home. And she also had restless legs during sleep. And she was also sleeping too long. She had a tendency to wander away. So she'd be going somewhere with family and then she'll just walk off. So they had to hold her hand. And she engaged in what we call simple stereotypies or compulsions. So she was constantly fidgeting. She was rubbing her fingers, tapping her legs, sometimes banging on the table. And these are things that are common in this kind of condition. Now, for those of you who will be familiar with the Minimal Mental State Examination scale, you'll know that that's a scale that has 30 points, and her score was 28. So for someone who had all of this cognitive and behavioral disturbance, typically we would expect a lower minimal mental score. But in the case of people with frontotemporal dementia, they often have normal scores. And that was what delayed the recognition of her condition when she first went to see the doctors, because when they saw this score, they assumed that it could not be a dementia. When the brain MRI was normal, but then when the brain PET scan was done, it then showed an abnormal pattern. What I write here is reduced FDG uptake in the frontal lobes. I will explain this later with pictures. We and others have basically recognized what we would consider the hallmarks of this kind of condition. So you can see what I've underlined here, that people have a progressive coarsening of their temperament, of their dispositions, of their judgment and comportment. So this is at the heart of what frontotemporal dementia is. Their social behavior is deranged. They have a dysregulation of emotions. What we mean by that is that they have poor control of how they feel, and so they tend to be very impulsive as a result. The same thing is true for drives. So there's a lot of overeating. And there's also, as I mentioned earlier, problems with language. Now, this is what we call the behavioral phenotype. It turns out that there are also people who instead have, when they first come to a clinic or when they first notice a problem, it's predominantly about language. And so they have problems with speech. Speech is either effortful and disjointed, and so it's broken, or it's fluent, as you would ordinarily expect, but it's also empty. That's what the word vacuous is referring to. It's empty, and it's empty because they have what we call anomia. That means they don't know the names of things, and they have word and object agnosia. That means that they see objects or words, and they have no idea what those things are. So I once met a lady who I introduced myself, and I told her I was going to be her doctor, and she says, "What is doctor?" She no longer knew what the word doctor means. And so these people have a progressive loss of vocabulary, progressive loss of object knowledge. And because of that, their speech is empty because they don't know what things are. They don't know what the words mean. Now, this has a historical context. I showed you a picture of Alois Alzheimer. The person to whom we give the most credit for describing the frontotemporal dementias is Arnold Pick, who was a prominent, was a leader of the Prague School of Neuropsychiatry. Alzheimer was at Munich. These were rival schools at the time. And he, along with Paul Serio and another colleague, were the first to report what we call primary progressive aphasia. And that refers to people for whom dementia begins with problems with speech, either speaking or understanding speech. But he also was the first to describe the behavioral syndrome that I've been describing to you, and to then show that it related to changes in the brain, which I'll show you in a moment. And since then, other people have built upon that work. And starting in the late 1990s, we started to realize that before that, it became clear that this condition tended to cluster in families, more so than, say, Alzheimer's disease. And it was starting in the late 90s that we started to identify the specific changes in the genetic code, what we call genetic mutations, that cause frontotemporal dementia in some families. And we'll talk about that in a minute. We believe today that we've discovered the most common genetic mutation. So here is the other brain slide. This will be the last one. Again, if this is troubling to you, please look away. The key thing we're not going to dwell on this. The key thing that I want to show you is what we call a knife edge atrophy. We call it knife edge atrophy because you can almost draw a line here, demarcating the areas where the gyri are full and the sulci are narrow, from the area where the gyri, as you can see here, are very thin and the sulci are wide. So there's atrophy, or rather degeneration, shrinkage of the frontal lobe of the brain. And you can almost, as I say, draw a line dividing the unhealthy part of the brain from the healthy part of the brain. And this is what Arnold Pick first described. Now, when we look at things in a microscope, as you can see from this panel, I won't spend too much time describing this. I just want you to see that these are very different from the plaques and the tangles that I showed you earlier. In Alzheimer's disease, most of the pathology is within the brain cells. There are different clumps inside the brain cells. So it's not just tau. Remember, I mentioned tau earlier, but also what we call TDP43 or FUS. FUS. So these are the other kinds of pathologies that you'll find. You'll find them in frontotemporal dementias. You will not find amyloid in the brain of someone with frontotemporal dementia. So amyloid is a thing at the molecular level that distinguishes Alzheimer's disease from the other kinds of dementia syndromes. Now, in the frontotemporal dementias, there are, as I said, tau, TDP43, and FUS abnormalities. The most common are either tau or TDP43. Now, frontotemporal dementia is typically a dementia of midlife. So the peak age at which people develop this is mid-50s. In the literature, cases have been reported as young as 21, as old as 75. I've actually met someone who developed frontotemporal dementia in their 80s. So it's a wide range. It can happen at any age in adulthood, but most people develop it in their 50s. Some people, and many do develop it in their 40s. We estimate that in the United States today, there might be about 100,000 people. We don't have accurate estimates. It's harder to estimate it. It's underestimated in elders in part because some people with frontotemporal dementia have a lot of memory impairment, and so it mimics Alzheimer's disease, and then they get an Alzheimer's disease diagnosis. Most research reports suggest that it affects men much more than it affects women, particularly the behavioral version. And as I said, in about 40 to 60% of people will have a family history. But they're not all hereditary cases. So what's the difference between having a family history and having a hereditary case? So when we say I have a family history, that means you can pinpoint a relative who might be an immediate relative or a relative in the extended family who has the condition. So it could be a cousin, an aunt, a grandparent, maybe even a parent. When we say it's hereditary, we're saying that there's a mutation, a genetic, an abnormality in the genetic code that is being transmitted through the family. So not everyone who has a family history has a hereditary mutation. Or to put it differently, not everyone who has a family history is necessarily going to pass this condition to their children. The patient I described earlier, this is her family tree. And this is her right here. That's her mother, who developed the condition, as you can see. So here, she developed this at about age 61, as did her mother. And her aunt developed a condition at 72, her cousin at age 62. And if you go back, her grandmother also had the condition, as did two other sisters of her grandmothers. We call this a 3-generation pedigree. So this is generation 1, 2, 3. We believe that one of these parents carried the mutation, but we don't have enough information. And this goes back, I think, into the 1800s or so. This is what generally we would require as the standard of proof that it is hereditary, that you have a 3-generation pedigree, and a direct line. So if this person were unaffected and there were people affected in this generation and in this and over here, we would not be able to say it's hereditary. It has to pass directly from parent to offspring for it to be called hereditary. And we're confident that that's what's happening when we have 3 generations. So that will be important when we get back to the issue of genetic testing. These are the known mutations. These 3 in the tau gene, progranulin gene, and C9 or CI9 ORF72 together account for well over 95% of all hereditary FTD. There are other genes in addition, but those are the major ones. Now, when a person has an FTD gene, it's an autosomal dominant transmission. What does that mean? There are some diseases where you have to have 2 abnormal copies of the gene to develop the disease. And if you only have 1 abnormal copy, you're a carrier, but you're not affected. What that means is that you can pass on either the carrier status, or you can have a child who's also a carrier, or if you happen to have married another carrier or to have a child with another carrier, you could then have, if the child were to inherit the abnormal copies from both parents, they could be affected. Every gene has 2 copies. And so when you have a recessive gene that's abnormal, that means the normal copy overrides the abnormal copy. Now, when it's autosomal dominant, on the other hand, the abnormal copy overrides the normal copy. It turns out that all the genetic mutations that cause the major dementias are all autosomal dominant. What that means is that the abnormal copy will always override, and the gene is passed. If the gene is passed, the person will develop the condition. Now, when we say penetrance, what we're referring to is, given you have inherited a bad gene, how likely are you to express the disease? Some diseases do not have 100% penetrance. What that means is that a person can have an abnormal copy of a gene and never develop a full-blown syndrome. It turns out that the evidence suggests that for frontotemporal dementia, for Alzheimer's disease, and for other conditions that are other neurodegenerative conditions, abnormal genes are essentially 100% penetrant. In the case of the frontotemporal dementias, the earliest people who carry mutations the earliest age at which people develop the disease, given they carry the mutation, is about age 45. About 50% of people who carry mutations will have symptoms by the age of 60. And most are going to develop it by the age of 70. And we don't know yet what governs the specific factors that govern age at onset. We do know that family history is the strongest predictor of the age at which a person will develop a mutation. If you recall, when I showed you that family tree, most, not all, but most of my patients' relatives developed the illness at about the same age. So that's an area of investigation. Okay, so the person has developed frontotemporal dementia, whether hereditary or not hereditary. Things progress gradually. That's what this graph shows you. So early here means to the early stages of the disease, middle stages, advanced. The principle here is that if it's frontotemporal dementia, the first thing to develop will usually be behavior, but it could be language, as I've mentioned. And that will gradually progress. And then people start to develop problems with executive functions. Executive functions are things to do with concentration, multitasking, switching your attention from one thing to another. And so they tend to have trouble with concentration. They tend to be distractible. And that tends to also appear in the early phase. Language starts to appear soon thereafter. And memory and disorientation, forgetting and disorientation are late developing phenomena. Now, the order can be changed. So for some people, it's executive dysfunction before behavior. For many people, it's language first. These things then progress together. Understanding this is important for diagnosis, as I will get to a bit later. What's a life expectancy? I've often been approached by people who will ask me how long, is it true, for example, that Alzheimer's disease progresses frontotemporal dementia progresses faster than Alzheimer's disease. Now, I haven't mentioned so far that frontotemporal dementia can occur in association with ALS. So there are families where people inherit either frontotemporal dementia or ALS or both. So they develop a condition known as FTD-ALS. Some other people develop what we call progressive supranuclear palsy, where they tend to fall. They have executive dysfunction, they have some behavioral dysfunction, and they tend to fall backwards. And people with cortical basal degeneration, the main problem is a problem with praxis. Now, if you remember in the beginning, I talked to you about praxis, the ability to execute skilled actions, to execute motor actions. So these people often, at the beginning of the dementia, the problem they have is they can't control their hand. Or the hand might actually be doing something that they disavow, saying, well, I can see my hand is moving, but I didn't ask it to move, that kind of thing. And they tend to be clumsy because they don't have control of the hand or their leg. It could be the leg. So that's called cortical basal degeneration. These conditions, progressive supranuclear palsy or PSP and cortical basal degeneration or CBD, are part of the FTD family. Now, the point of this slide is to look at life expectancy, And so Chiadi Onyike, who was working with me at the time, collected data from all clinical reports that described illness, the duration of the length of time that people had lived with the condition. And we plotted that here, and we plotted that in relation to Alzheimer's disease. So this line here this top line is Alzheimer's disease AD. These are the people with behavioral versions of frontotemporal dementia, and these are the people with the language versions of frontotemporal dementia. So as you can see, basically, when people have behavioral or language-based frontotemporal dementia, they don't have a shorter life expectancy. You can look at the numbers over here. These are basically average years lived with the condition. We now know the estimate to be about 8 to 10 years. So there's no real difference between Alzheimer's disease and behavioral frontotemporal dementia or the language versions of frontotemporal dementia. There is a difference, a substantial difference between people with other forms of frontotemporal dementia and those who have FTD-ALS. These people live on average 2 to 3 years with the condition. So this is rapidly progressive, similar to the speed at which typical ALS progresses. For those of you, I should have said this earlier, but ALS refers to Lou Gehrig's disease. So frontotemporal dementia progresses at about the same pace as Alzheimer's disease, except in the case where people have FTD with ALS. Those people with FTD with ALS progress very quickly. That's what this line depicts. Most people progress on a trajectory that means that their life expectancy is 8 to 10 years. Sometimes we observe 13, 14, 15 years. More recently, there have been a minority of people for whom FTD evolves very slowly over 20 to 30 to 40 years. So this has been a more recent discovery, and the discovery of genetic mutations has allowed us to basically confirmed that some people who looked like they might have FTD but weren't progressing the way we expected, didn't have all the symptoms that we would ordinarily expect, do indeed have frontotemporal dementia, because in some cases we've had the opportunity to examine the brain, but in many other cases they carry a hereditary mutation. So we have regular progression where the life expectancy is 8 to 10 years. We have rapid progression, typical of FTD with ALS, where life expectancy is 2 to 3 years. And we have slow progression FTD, where people can live as long as 30 years with the condition. It's comparatively rare. All right, so we'll slow down a bit. We're now going to talk about what happens. Now that you have all this background, and I know that there's quite a bit, I hope most of it is sticking. Let's talk about what happens in the clinic. So someone comes to me and there's for an evaluation. The most important thing by a long distance for making a diagnosis for whether it's for Alzheimer's disease, for frontotemporal dementia, for something else, is the clinical interview. So the clinical interview is crucial. And I will explain some more a bit, but mainly when you're doing the clinical interview, what you're asking for are 4 things. One is the presentation. What is the first thing that developed? Was it memory? Was it forgetting? Was it the person's behavior? Were they too garrulous? Were they gobbling up food in an uncharacteristic way? Were they doing things that were odd? Were they having trouble speaking? And so on. How fast was it progressing? How fast were these changes occurring? What came next? Okay, so memory was first, what was next? What came after that? And how did all of that unfold? And we also want to know, what are the complications? Does the person have a tremor? Are they drooling? Are they shuffling? Are they falling? We want to know the complications because in some cases, these are what I call complications. These are things that might help with diagnosis, but they often are things that will require management regardless of the diagnosis. For example, a person prone to falling, that needs to be known very early. The neurological examination helps us especially to document things like Parkinsonism, which will make people walk awkwardly, will explain tremor, might make them prone to falling. Once we have with a good clinical interview and a bedside examination, generally speaking, we should have a good idea what the most likely diagnosis is, and then we can use a brain MRI if we need to probe for. We use a brain MRI either to cement the diagnosis or to buttress the diagnosis. But sometimes we're still unsure, and the brain MRI or the PET scan will help. We should only be getting a brain PET scan if the MRI is abnormal. Right here, psychometry refers to the scales that we ask. So many of you will be familiar with the Mini-Mental State Exam scale with the Montreal Cognitive Examination, what we call the MoCA, which we use at the bedside not to make a diagnosis. Its purpose is not to make a diagnosis, it's to estimate the severity of things. But in primary care, the primary physician might use it sometimes because they don't have a lot of time to go through a full-blown examination, but they might use it to see if the problem is serious enough to be thinking about dementia. For frontotemporal dementia, that could be a mistake because many of these people, as I mentioned at the beginning, will have a normal score. More recently, CSF analysis has become useful. This is where you do a spinal tap, you get spinal fluid, you analyze it. And mostly in today's world, we're looking for amyloid and tau protein. Remember those 2 words I asked you to, those 2 proteins that I wanted you to keep in mind, amyloid and tau, because if they have amyloid and tau at certain levels in the brain, in the spinal fluid, then then that might confirm an Alzheimer's disease diagnosis. If there is no amyloid, or if the amyloid levels are extremely normal, then the diagnosis is very unlikely to be Alzheimer's disease. The genetic analysis is more useful in frontotemporal dementia than in Alzheimer's disease, but only in those people who have a 3-generation pedigree. Remember what we talked about, the 3-generation pedigree. If there is not a 3-generation pedigree, the chances that a person has a mutation are very, very low. the likelihood is that a genetic testing done in a person with no family history of dementia will be negative. And so if you don't have a 3-generation pedigree, then it's very unlikely that you have a hereditary frontotemporal dementia. So let's go into some of this. Here is a clinical history displayed graphically. I meet this person when they are 72 years old, right here. This is their first visit, and at that time they tell me that she doesn't talk much, so her speech is not spontaneous or has lacks of spontaneity. It's disjointed and it's empty. So it doesn't have a lot of information and it's not flowing smoothly. She tends to repeat specific words. When I ask her to repeat a sentence, she struggles. She has problems understanding what words mean. She has problems understanding full sentences, and so on. Now, it turns out that when I now ask, the problem began 2 years earlier, okay, with behavioral problems. So now I'm beginning to think frontotemporal dementia. She has language problems next. So that is strengthening the idea of behavioral dementia. She's gobbling up food, which is typical of frontotemporal dementia, but she has trouble swallowing. Now that's not typical of frontotemporal dementia. You have trouble swallowing if your swallowing muscles are weak. So that's the first clue that she might also have ALS. It turns out that when I'm seeing her, soon after I see her at the next visit, she's having trouble with the sound of speech. So she's talking as if her speech is very slurred. And so it became evident very quickly that she has FTD with ALS. Now she goes from being a little distractible and misbehaving to not talking much, barely able to communicate in a space of 2 years. And she has dysarthria. So she's on a fast timeline. So what we have here is a chronology, behavioral language, and some paralysis, okay? And it's happening on a fast timeline. So those two bits of information together illustrates a chronology and a speed of progression that makes the case for frontotemporal dementia with ALS. Now, using this kind of reasoning, therefore, we can say, okay, well, a person comes to the clinic and the problem is the heart of the problem is memory. That's how it began. That's what's most salient. Most likely it's Alzheimer's disease. If it's abnormal conduct, most likely it's frontotemporal dementia. If they come in with hallucinations and delusions, it could be dementia with Lewy bodies. If it's not a memory problem and you go further down, is it language-based? It could be a language version of frontotemporal dementia. Okay, it could be one of the language versions of frontotemporal dementia or a language version of Alzheimer's disease. So you can see very quickly how the clinical interview informs the diagnostic reasoning. And then you collect much more information that allows you to troubleshoot some of the other possibilities. Some of them are psychiatric. I won't spend a lot of time on this slide. Only to point out that, just a little bit to point out that if it's a psychiatric problem, typically you will hear that this began a long time ago, when they were 18, when they were 30. If it's dementia with Lewy bodies, hallucinations, paranoia, that would be the most prominent thing. If it's a vascular dementia, you'll hear a story about a stroke. When you do the neurological examination, you'll see evidence of a stroke, or should see some evidence of a stroke. And so on. So with the clinical history, you can make a lot of decisions. And then the rest of this here has to do with the tests to help you. This is a listing of the common bedside examinations. And we use these, as I said, to estimate, once you're zeroing in on the diagnosis, you might use it to confirm, to make sure that you haven't missed out in the history, maybe deficits in some other area. So it can help you complete the picture. But it's also important, its primary importance is for estimating severity. So then you do a brain MRI. I suspect frontotemporal dementia, I get the brain MRI, and here, what you see is shrinkage in the frontal lobe. If you remember when I showed you the brain pictures, I showed you shrinkage in the frontal lobes. And here you can see that on an MRI scan. Here, in a language version of FTD, what you see is bilateral, meaning both sides. The temporal lobes, which govern memory and language, are essentially destroyed, but they're selectively destroyed. This is another language version where a big chunk of the temporal parietal area is removed. These people struggle to speak. Now, when people have normal MRIs, then we can show, for example, reduction. You remember that term, reduction in FDG uptake? So we give people what we call F-deoxyglucose, which is a mimic of glucose that can't be digested. We tag it, we inject it, it gets in the brain, and the regions of the brain that are not active don't take up any because they don't need any energy or they're not consuming energy. And you can then see, as you see here, that the frontal lobe does not take up, has low uptake of FDG, F-deoxyglucose. So the problem in a person who has a normal MRI, the PET scan shows you that the energy map of the brain, the PET scan shows you an energy map of the brain showing that there's no energy in this region of the brain, in the frontal lobe. So this confirms the diagnosis of frontotemporal dementia. Same patient, low uptake in both temporal lobes and in the frontal lobe. So that's frontotemporal dementia. A different patient, same thing, low uptake in the frontal lobes. So the PET scan is valuable when the MRI is either normal or ambiguous. If you have an unequivocal MRI, such as here or here, there is no need to do a PET scan. If you have a 3-generation pedigree, this is another example of a 3-generation pedigree. Affected person with ALS has 2 children, one with FTD, one with ALS, and one of those people has a child with FTD. So that's another 3-generation pedigree. And what this does is it adds a different twist to that, to the statement I made earlier about, excuse me, to the statement I made earlier about the 3-generation history, which is that it's not just a 3-generation history of dementia, it's a 3-generation history of dementia or ALS. And today we interpret that a bit more loosely to say if the person has a history of dementia, if the family has a history of dementia, ALS, or Parkinsonism, we would count that for the purposes of establishing this 3-generation story, which would then justify, or rather I should say trigger, genetic testing. Now there are a few caveats. Sometimes you don't have enough information. This generation is unknown for one reason or the other. Or if this person had passed away at say age 22 in a car crash, what you would end up with is a 2-generation pedigree. But in that 2-generation pedigree, you have a parent and you basically have a father and an aunt with this syndrome. So in this situation, I would still go forward with genetic testing, unless the person didn't want to. So even though I say 3-generation pedigrees, there are caveats. Now we're back to that term amyloid. In the last 5 years, amyloid PET has come to the market. What that means is that we can now do PET scans where you inject something that will go into the brain and stick to the amyloid protein so you know it's there. It used to be that the only way you could establish that that plaques were in the brain was to examine brain tissue, which meant either do a brain biopsy or do a post-mortem brain examination. Now you can actually have a person do a PET scan and you can see whether there's amyloid in the brain or not. If there's amyloid in the brain in the right amount and distribution, then you have practically confirmed that this person has Alzheimer's disease. You can also, we now have the same thing earlier this year. Many may have missed, some of you heard the news, some of you may have missed it because the pandemic dominated the news, but in May this year, the first tau PET scan was approved by the FDA. So a person can have a negative amyloid PET scan and have a positive tau PET scan, in which situation the most likely explanation would be that they have frontotemporal dementia. So this is a person with frontotemporal dementia. This is their MRI scans. You can see the frontal lobe shrinkage right there, and right here. And the yellow and pink basically signifies that they have a lot of tau in their brain. So this is a person who has frontotemporal dementia. So the diagnosis of frontotemporal dementia, of degenerative dementias, is really becoming more and more sophisticated in terms of the technologies. Looking to the future, one of the active areas of development is trying to get a similar kind of PET scan for alpha-synuclein, which will allow people to essentially establish the diagnosis of dementia with Lewy bodies, or Parkinson's disease dementia, by doing a PET scan, because then you can basically tag alpha-synuclein, which are the abnormal proteins in dementia, Lewy bodies, and Parkinson's disease. Similarly, for those forms of frontotemporal dementia that have TDP43 protein rather than tau, we are not yet at the point of developing PET scans for them, but when we are able to, we will be able to do something similar. Today, the value of amyloid PET and tau PET is, if you're saying, well, it looks like FTD, but it could be AD, you can do an amyloid PET scan, and if there's no amyloid, then you know it's frontotemporal. Then you can settle on frontotemporal dementia as your diagnosis. And if it is a positive PET scan, then you say, okay, well, it does have elements that look like FTD, but it really is Alzheimer's disease. Visual ratings, where you can basically grade. So these are basically grades of severity. You can actually create it. We've actually created scales. There are different kinds of scales that are created. They're quite reliable. So people, two different people rating them will agree 70% of the time. The same person who comes back and looks at the same PET scan without knowing that they're looking at the same, sorry, at the same MRI scan without knowing that they're looking at the same slice, will reach the same conclusion more than 80% of the time. So imperfect, but still quite good. And these are typically used in clinical trials, where the question is, okay, we are giving the person a drug. Can we say that atrophy is not progressing? And you use the scans to make that determination. So you do serial MRIs over a period of time, and you have people rate them over time, and then you see if the people who are receiving the drug, for example, tend to stay closer to 0, whereas those who are not receiving the active drug drift towards 4. Then that would be some kind of evidence that's not about symptoms, but it's about brain atrophy, which would serve to increase confidence that a drug is working. These things are not being used today in clinical care. It's mostly intended for research, these rating scales. So when we have made a diagnosis, so we're faced with a person who has dementia. Typically, when somebody walks through the clinic door, at least through our clinic door, I see our role as multifaceted. Some people are coming because there is a problem, something has changed, and they don't have an answer to it. So they know that there's a disease or a disorder, but they don't have an answer. And they need that answer in order to begin to do the things that need to be done. So in that case, my role is to make a diagnosis, to tell them, to be able to collect the information, to be able to say, this is what is going on. Sometimes it's a crisis, or a person is not doing, and the crisis could be a person is floundering at work, and they've been told that they need to get an evaluation, or they've been told that they're in danger of dismissal. And so they've come with a practical problem. I'm having these problems with my thinking abilities, or they're having problems with their behavior that is threatening work. And so in that case, the question is not just about the diagnosis, it's about solving that problem. How do we ensure that they don't get dismissed? How do we ensure that their income is secure long enough, meaning through disability benefits, that income is secure and long enough for there to be a plan B to be brought to bear? So that's more of a crisis intervention role and a rehabilitative role, because sometimes there are things that can be done to help the person stay in the job longer. Sometimes it's distress. The person is agitated, they're belligerent, they are frightened, and nobody has been able to sleep for some time. So yes, it will be helpful to have a diagnosis, It'll be helpful to have some strategies, but right now they really need some relief. And that relief may come in the form of arranging for this person to be evaluated further in the hospital. It may happen in the form of medications being prescribed. In other words, we're prescribing some action. Hospitalize, go to such and such program, daycare program, for example, or take such and such medication. Now, I've also had occasion to evaluate, to do evaluations where people already have a diagnosis in hand. The person is retired. There's no other kind of crisis going on. There's no distress. They just are not sure what's next or what to do next. They haven't, they're between physicians, or they're not satisfied with the care they're receiving, or the person who's providing the care is telling them, look, this is not my this is not my area. It's, let's help you get to someone who specializes in this. So they've come for guidance. They need clarification where they are in this process. How severe is it? What's to be expected next? What should they be doing? What preparation should they be done? So all of these things together, providing an explanation, solving problems, providing relief when needed, providing guidance through the process. All of these together constitute the dementia care role from the point of view of a neuropsychiatrist such as I, or a behavioral neurologist. And we bring to this role a range of interventions that one would hope would be tailored to the individual and to the person around and to the people around them, to the individual and their care partners. What we would all like to see is curative interventions. I think this is true for everyone. We want to be able to prevent it to begin with. And there are some things that we talk about for preventive care, maximizing socialization, maximizing physical fitness, regular exercise. Recent data suggests that sleep is crucial, particularly for Alzheimer's disease. Sleep hygiene, 7 to 8 hours per night if you can. Because sleep is when the brain does its housekeeping. So there are a number of things that we're learning, and the diet as well. So there are a number of things that we're learning about how you can push back on the risk for Alzheimer's disease or for frontotemporal dementia by doing things that are essentially wellness investments. Beyond that, we're also beginning to look at, and this is where we'll get into the research, we're beginning to look at how can we know who is at a higher risk than the other when everybody has no symptoms, when people don't have symptoms, and what can we do in advance of symptoms developing. So we're looking at, and for that matter, if a person does have symptoms, can we reverse them? Can we stop things in their tracks? And people have developed molecular targets with the idea of cure in mind, and we've developed pluripotent stem cells to begin to look at how you can do brain reprogramming. Reestablishing synaptic connections so that you can essentially reset the brain's capacities. People are looking at neuromodulators to do some of the same things. So if you can stop dementia in its tracks, can you use brain stimulation paradigms or basic devices to replace what's lost, or to stimulate the brain to function, to do the same function using different pathways? And so the brain stimulation research in Alzheimer's disease and frontotemporal dementia is growing quickly. We have medicines. When we're talking about amelioration, we're really talking about dialing down symptoms. And that often comes down to medications to deal with anxiety, depression, hallucinations, delusions, and so on. Sometimes it has to do with psychotherapies. So a number of years ago, there was a patient who he had this compulsion. He had this idea that he had to check the suspension of every car in the neighborhood. And it turns out that in today's world, most cars have alarms. And so he was creating a racket and driving the neighbors up the wall. And this was a compulsion, and it was difficult to reason with him. So finally, someone sat with him and said, look, you're shaking the car. That's not how to do it. That's old school. Here's a new way you do it. You just need a checklist. And so he was given this checklist and how to look at the car from this angle and that, and was instructed it wasn't necessary to touch the car. This is the modern way to do things. And so you couldn't stop him from this compulsion, this idea he had to check the cars and their suspension and their tires. But he was now retrained, which is a psychotherapeutic approach, essentially. Retrained to do the same compulsion in a way that wasn't nearly as offensive as what he had been doing previously. So you've ameliorated a behavioral problem. You haven't reduced the symptom necessarily, but you've reduced its impact. Rehabilitative interventions, on the other hand, are basically intended to shore up skills, and typically these take the form of physiotherapy, for when people have gait disturbance. But there are other things that can be done. So a person has a bad tremor, for example, and is having trouble eating or holding a cup of coffee or something. And what you do is you could do a simple intervention. You can give them a heavy spoon. So there are weighted utensils. One can go on Amazon, you'll find a whole range of weighted utensils. So the heavier the utensil is, the less likely it is that tremor will result in the person not being able to eat properly. That's just one example. A person sways this way and that. Well, a heavy vest, and there are actually weighted vests, might reduce that stagger and help them keep their balance. A walker, as you all know, a walking stick, these are things that we do to reduce the risk for falling. And those are things that are targeted at individual to sort of rehabilitate them. If they're early enough in the symptom, you can teach them brain exercises to shore up certain cognitive areas. You can teach them workarounds to address weaknesses. So a person who's forgetful can have memory aids that they refer to. And those are rehabilitative interventions that are aimed at the individual who has the problem. But you also have carer skills programs. Problem-solving therapy is one way you can actually train caregivers to troubleshoot problems in real time, and thereby increase their effectiveness as caregivers. Now, we also, unfortunately today, eventually have to look in the direction of palliative care. Palliative care does not necessarily mean end-of-life care. It's an orientation where you're saying the emphasis now is quality of life. So some of these things include dietary interventions for people, for example, who are having trouble eating. If a person has FTD-ALS and is struggling to swallow, rather than try to insert a stomach tube, you could engage in some palliative interventions to try to ensure that their nutrition is adequate and that they're able to eat without choking, without aspirating. And so this is where home services and equipments come to mind. If it's a multi-level home, you could put a Hoyer lift so that the person doesn't have to walk the stairs, or the person might not even be able to walk the stairs any longer, but you can still transport them up and down with a lift. And so there's a whole range of palliative interventions that are available, and strategies that are available to help and optimize quality of life. There are a number of other things that we have called existential issues. So the paper that Marianne Wiley, who's the nurse manager in our clinic, wrote a number of years ago, describes some of the ways in which we deal with some of these issues. Big ones that come up have to do with decisional capacity, and the idea of advance directives and power of attorney. Generally, I advocate the power of attorney over advance directives, because I think if there's a care partner who knows how you would want things to be done, understands your values, understands your preferences, knows you as a person and what you need, and is empowered to help physicians and other health providers make the right decisions for you. I think that allows reaches a good what's the word I search for now? It allows people to have a good balance, to achieve a good balance between what your best wishes would be, what your needs are, and what the situation is providing. Because sometimes it's very difficult when you use advanced directives. One of the problems with one of the limitations of advanced directives is that you can't really predict the future scenarios. So you're putting in place rules about scenarios that you don't see yet. And so that can be challenging in real time. Whereas empowering a reliable person allows flexibility. Ultimately, from our perspective, the most important thing when you're talking about disability, competence, and decisional capacity, the most important issue is you're trying to facilitate the individual's life participation. So we take a life participation perspective. We're not saying you're too disabled to do that. We're saying, how can we help you participate in life to the extent you can? Now, this really is a big thing when, for example, we have to adjudicate driving. Can the person still drive? And we take the view that we want people to participate in their lives for as long as is possible in a manner, of course, that is safe and reasonable. But we don't want the diagnosis to become every disability. So you don't want the person comes to the clinic, having driven there, you make a diagnosis and say, okay, now that I've made this diagnosis, stop driving. Because nothing has changed between the time that they walked through your door and the time you made the diagnosis. That nothing has changed with respect to the driving. If they drove safely to your office, they can drive safely back. And when you now declare a handicap on the basis of the diagnosis, you really interfere with people's capacities to participate in life. And so it has to be a more nuanced approach. And so these are some of the kinds of things that we navigate when under the banner of existential issues. They're really about living life issues. How do we ensure that we minimize crisis or conflict around basic questions of being able to participate in one's life? So these are some of the responsibilities of someone who is involved in this role, is to find ways to ensure that people can live as best they can. Another big area is when people have trouble feeding, and that's typically an end-of-life issue. How do you, one of the questions we have fielded, particularly people with FTD-ALS, is should a stomach tube be put in? We generally have not advocated for one, because the data does not indicate that where dementia is concerned, life will be meaningfully extended by putting in a gastric tube or a stomach tube. And the evidence also does not show that life participation is facilitated by doing so. And there's a substantial risk of conflict around the tube, because the person doesn't know what the tube is there for, but they can feel its presence and they can feel discomfort, and you could find yourself in a situation of having to restrain them just to protect the tube, which then creates a certain absurdity. So on balance, we think that the evidence and the practicalities do not favor putting in feeding tubes. But there are strategies that can be used to ensure that a person who's having trouble swallowing can get adequate nutrition. And we package those for people. Sometimes we get a swallowing evaluation so that we can pinpoint the stage of swallowing that's dysfunctional, and then that helps with articulating an intervention, basically a therapy intervention to maximize nutrition. Now, there are times when we have to prescribe medicines, and most of this is borrowed from standard psychiatric practice. So, for example, we would use things like sertraline, which many might know as Zoloft, other SSRIs like fluoxetine, which is known as Prozac, will be used to address things like depression, anxiety, irritability. And it happens that they are also effective for compulsions, not always, but now and again. And if a person has hallucinations, delusions, we have medicines that can help with that. One of the more difficult problems is overeating and roaming. These tend to be the two problems that are very, very difficult to deal with by prescribing a medication. But sometimes topiramate, which I have at the bottom of the list, can help with people when the problem is overeating, particularly if the overeating is compulsive, if the person is actually looking for food when there's no food. Some people who overeat who have frontotemporal dementia or another kind of dementia, for them it's that they don't know when to stop. But if you remove the food, they stop. But for those for whom for those who will forage and keep eating all day and topiramate might be something that can help. Now, finally, the care partnership extends beyond the home. And so there's a whole system of advocacy and care support for, in terms of Alzheimer's disease, this is provided by the Alzheimer's Association. For frontotemporal dementia, it is provided by the Association for Frontotemporal Degeneration. For Lewy bodies, there's the Lewy Body Disease Association, LBDA. And there are others. So for these various neurodegenerative diseases, there are a number of, there are different organizations that have in common advocacy and care support as the mission. And some of them are more developed than others, have more resources than others. So the Alzheimer's Association, for example, is the biggest, but the Association for Frontotemporal Dementia has been extraordinarily successful as well. They provide care support. They run an FTD registry where people can, if you have a diagnosis or you're a care partner or you're a relative, you can go and register on the registry and say, this is who I am, and I'm available to participate in research. The research might be surveys, it might be more involved. You can also participate in advocacy and volunteerism. And you can navigate to find clinical trials. You can navigate to find healthcare professionals in your area. You can navigate to find support groups. So these partner organizations are very, very helpful, very, very important for helping people live in their journey with these conditions. So what I've put on this slide here is the landing page, the current landing page for the Association for Frontotemporal Degeneration. And you can find them if you put in your browser aftd.org. It will take you right there. Now, another kind of partnership involves the professionals, the research and clinical professionals. So this is the North American Consortium, the All FTD Consortium. There is also a partner consortium in Europe, headquartered in London, in the United Kingdom. There's a partner association in Australia and New Zealand, as well as in Southeast Asia and in Latin America. So all these consortia, their mission is essentially to advance research in order to facilitate treatment development. So some of the discoveries, for example, firstly, that you can see in people who carry mutations before they have illness. Some people have very soft, I call it soft because they don't affect life, problems in executive functions or in language that you'll detect if you test them, but they're not necessarily noticeable in everyday life. Some people have mild behavioral changes, same thing. They're not in any way noticeable. Or they might be noticed only as subtleties of behavior that can be explained by people who are close. The bigger discoveries, though, have to do with this graph I'm showing you, one of the bigger discoveries. So here, the GenFi group in Europe basically demonstrate. So they take people who have who carry mutations, and using the estimated, remember I told you that one of the best predictors of when a person who carries a mutation might develop an illness is the age at which relatives did. So you have people with who carry mutations who are 25 who are 5 or more up to 25 years out in terms of the estimated age at which they're likely to develop symptoms. And you do serial brain MRI scans, and you can look at the different brain regions. And what you can see is that the regions of the brain, the occipital and the parietal lobes, which together govern orientation and visual perception, do not have that much atrophy other than what might be explained by aging. In contrast, the regions of the brain that are typically affected by frontotemporal dementia, so here you have the anterior cingulate, that's this first graph. You have anterior cingulate, you have the frontal lobe, you have the temporal lobe and the frontal insular. You can see the trajectories differ from these other two. So these are steep declines that are documented as early as 20 years prior to the age of onset. So using something, this is not yet at a level where you can I can do a scan in an individual and say, look, I can see a slope. You see these curves because these people, this is a group, but a radiologist is not going to see a difference if they looked at a scan at this point here and looked at another scan here. They probably won't see a difference. But when you look as a group, you can see it. And if you did serial scans in an individual, you might be able to plot enough of a line to say, well, perhaps this person carries a mutation. The more important value of this, though, is not for trying to identify who carries the mutation or not, because you can simply do the genetic testing. The more important value is that this provides an avenue for testing new drugs when your goal is to prevent clinical symptoms. So this is the line at which clinical symptoms develop. So imagine that you could give a drug at this point and then straighten out these line or that line or the other one. If people don't have symptoms, the only way in which you can test a new drug is to test the biology. That means look at atrophy rates or look at some other biomarker in the, something that you can measure in the blood or in the CSF. And there's some of that research going on as well. And here we're looking at progranulin assays in people who carry mutations. Now, it turns out progranulin assays are mostly relevant to people with progranulin mutations, so they're not as useful for the broader population of FTD, but they still provide some hope. So here are normal people who have, these are the average progranulin levels in people who are normal. These are the people who carry the mutation but have no symptoms, and these are the people who carry the mutation and have symptoms. So you can see that early on, years and years before people have symptoms, if you carry a progranulin mutation, you already have a low progranulin level. Now, here we're, one of the things that we're still trying to understand is whether the progranulin level provides a gradient that allows you to assess treatment response. But what it could do is, what you could do as a target, and this is what is happening in, this has become of considerable interest to drug development, is you could measure normalization. So you can measure treatment effect, not necessarily in terms of how much things improve in time, but by moving this average up. So if you give people a treatment and these people now have levels that are here or here, you can demonstrate that treatment has had an effect. And so this has become very helpful for drug development. This is neurofilament. This time we're looking at measurements in the CSF. And here again, you can see the people with the patients. You can see the controls. You can see that there's a distribution here in the patients that differs from that in the controls. We don't yet know if this tracks with disease severity, and the data currently suggests that it might be more a measure of when things begin to be, when people make that transition from mutation carrier with no symptoms to mutation carrier who is developing symptoms. And so much of the research now is zeroing in on trying to characterize how neurofilament might be useful. So this is just an example of the kinds of things that these research consortia are working on. And they're working on these things using as their model for disease, what I show you here, which is basically the idea that the person has a normal clinical status. That means they have no symptoms for many, many years, okay? But if they are in an unfortunate group, then what is happening is that the brain volume is gradually changing, as I just showed you. And at the same time, something like neurofilament or some other pathology that we don't already know might be coming up. And the neurofilament level is not changing, it's changing gradually, but not too much. Inflammatory markers are changing, but these two things together trend upwards at a time at which a person is basically developing symptoms. So they are markers of the change from asymptomatic to symptomatic status. A molecular pathology is basically a marker of the disease process that is happening and is the cause of all of this other stuff. And the brain volume, when it hits a threshold, dysfunction begins. When, the atrophy, when it hits a threshold, dysfunction begins. And all of these translates to a change in the clinical state. And it's at this point that we're calling, it's beyond this line that we now say dementia. And beyond this line, what you then have is high neurofilament levels, low brain volume, clinical abnormalities, high levels of the molecular pathology, and some evidence of growing inflammation in the brain. So this, we are trying to understand precisely what these relationships are. So this molecular pathology here refers to the accumulation of tau, TDP43, FUS, or something else, depending on the form of dementia. So this is the working model. And what we are trying to do essentially is put numbers to all of this, identify specific markers and their roles, and use all of this information to identify candidate mechanisms for disease, which will then form our targets for drug development. This list here, I don't expect you to understand most of the terms here. And I've put this here because there are a number of them. And the purpose is to show that we have many potentially productive avenues for developing drugs where our objective is not to reduce symptoms, but to halt progression. And hopefully to reverse losses. Now we are doing, so Hopkins is part of the consortium. We are also involved in studies focused on young-onset Alzheimer's disease. We are involved in neuromodulation studies, mostly so far focused on the language version of frontotemporal dementia, but we're expanding into the behavioral version and into Alzheimer's disease. So these are brain stimulation protocols. We have involvement in clinical trials for PSP, for dementia with Lewy bodies, for other Parkinsonian disorders. We have a process for helping people get genetic testing. And we have a brain donation program that is supporting all of this research. I will thank you for your attention. I'd like to thank you all for your attention, and I look forward to your questions. This slide here is intended to also acknowledge that, it takes a community to fight back against these diseases. There is a community of patients and families and the advocacy organizations, as well as a community of physicians, nurses, other health providers, and researchers. And together, we're going to turn back the clock on these diseases. Thank you very much for your attention. I will take your questions now.
Thank you, Dr. Onyike. We have received so many questions. I'm not even sure where to start, but a lot of interest around medication. And I guess maybe you could talk more about medication specifically for FTD.
Shall I take down my slides or go back to the slides, or what do you want me to do?
Probably take them down.
Okay.
Yeah.
All right, so I'll talk about medications now. Right now, medications are mostly aimed at relieving symptoms. As I mentioned, the medicines that we're familiar with for treating depression and anxiety. So these would be, if I may use brand names, these would be Prozac and Paxil, Zoloft, and so on, Lexapro. They can be helpful for anxiety, they can be helpful for depression. They're often helpful for irritability as well, and for compulsions. Sometimes we have to resort to stronger medicines to deal with intense compulsions, and in those cases we might be using neuroleptics. Some people are familiar with quetiapine, which is also known as Seroquel, with olanzapine, and so on. We reserve things like haloperidol, risperidone, and the like for when people actually have hallucinations or delusions. Now, in terms of, so we use psychiatric medicines, but that's mostly for symptom relief. Now, in terms of dealing with the cognitive decline, amantadine in the clinical trial that I mentioned at the beginning, the clinical trial demonstrated that it doesn't help. Other clinical trials have shown that the cholinesterase inhibitors like donepezil or Aricept, medicines that are typically prescribed for Alzheimer's disease, are not helpful in frontotemporal dementia. In our experience, amantadine can help boost cognition, attention, speech, especially executive functions. So we prescribe that quite frequently. There are no other medicines that are targeting, well, actually that's not completely true. Sometimes people use brain stimulants like methylphenidate, which many of you will know as Ritalin, to try to boost attention.
Okay.
And it's mixed results really. I found that it helps, maybe it doesn't, it helps sometimes, but more often than not, it's not effective. We've tried Wellbutrin for the same purpose, to try to boost cognition, and we've had some success with that. But it ends up being very much trial and error.
Okay.
But the new generation of clinical trials that we're setting the stage for today, and some of the trials that are currently underway, are focused now not on ameliorating symptoms, but on halting neurodegeneration.
Okay. All right, another question. Is there a correlation between FTD and a prior brain injury?
That's an excellent question. The early studies, we did an analysis here that didn't show a correlation. Early studies did not. Now, when we're talking about brain injury, we're talking about maybe somebody suffering a serious brain injury in a crash, in a fall, in an assault. Now, when you now look at it in terms of repetitive head, concussions, the pathology in what is called chronic traumatic encephalopathy is essentially a tau-based pathology. So it's very similar. It's very similar to the tau version of frontotemporal dementia. And in fact, I had a patient who had the symptoms of FTD, had all of the brain findings. When he passed, he was a former NFL player. And when he passed, they did a brain examination, and they concluded that he had his brain was included in the NFL study, and they concluded that he had chronic traumatic encephalopathy. So some of us think that in terms of the pathological state in the brain, the accumulation of tau, and in terms of the pathological, the brain atrophy changes, that you could actually make an argument that that CTE is a form of FTD.
Okay. Another question, which will probably be relevant to many, a question around at-home testing, like 23andMe, is it valid for determining one of these mutations, or could a neurologist interpret it, or should the individual get a test done at a hospital or clinic?
Thank you. That's a wonderful question. I've seen a number of people, actually I've received a number of messages from people saying, I have this allele and I have that allele and I have the other one. Well, you're going to have the allele for every gene. These genes are real. They're normal, they have a normal function. But when 23andMe does this testing, they're not testing for mutations. They're telling you have the gene, because the gene is there. Everyone has those genes, but they have normal genes. So 23andMe is not the way to do genetic testing, because they don't do testing for abnormal genes. And so it's not genetic testing that can be interpreted in terms of a risk for any disease. What you want to do is test specifically for mutations if you have reason to. And that's best done through a genetic counselor. Now, a neurologist can, or in my case, a neuropsychiatrist who specializes in these conditions, can order the genetic testing, but I would recommend that you first see a genetic counselor, because they'll help you draw out the pedigree, the family tree, make sure it's correct. And by drawing out the family pedigree, they'll make sure that you do the full panel of genetic tests that are plausible for the problems that you're describing. Because what you don't want is to zero in on a specific gene, get a negative result, and say, well, maybe we should have tested for the other gene. These things are expensive, or they can be, especially if you're paying for out of pocket. So it's best to first draw out the pedigree, get all the symptoms properly mapped. We've had situations where we find that we're saying, okay, we're going to test for the Alzheimer genes, frontotemporal genes, leukodystrophy genes together, so that we don't come back to it.
Okay. Another, kind of going back to medication, is there any research into herbal medicine for treating any of the dementias?
No, well, some people are interested in CBD oil in particular. Things like coenzyme Q10, selegiline, ginkgo, and so on, all of those have failed in clinical trials. Even curcumin has failed. The thing that people are looking at now is CBD oil, but they're not looking at CBD oil in relation to stopping neurodegeneration. It's more in relation to controlling behavioral problems.
Okay. Another attendee asks a question. Her mother was diagnosed with vascular dementia, and it is mild at this time, but it's getting worse. And her biggest problem is trying to understand which doctor to take her to work with her, a psychiatrist or a neurologist.
If the problem is behavior, if what she's struggling with is behavior or coping with problems, then it makes sense to go to a psychiatrist. But you want it to be a psychiatrist who actually works with people who have dementia. I wouldn't go to just any psychiatrist, because many practicing psychiatrists don't really know what to do.
Okay. And another attendee would like you to talk about PTSD and how it may present in dementia.
Another fascinating question. A number of years ago, I met a gentleman who was invited to see because he had been crying a lot lately, waking up and screaming during the night. It turned out that he had served in World War II. That was a generation that's very humble. People who served this country with a great deal of humility. Didn't come back to talk about what their wars, about their exploits or even about their struggles. They came back to reintegrate and live family lives. So this man had never told his family about his war experiences. It turned out that he had served in a unit that was responsible for burying dead colleagues. And so before every major offensive, colleagues would shun him and the other two, because it was bad luck to associate with them. Mm. And so while people back home thought of him as a hero who served his country, he and his colleagues did not have that particular experience, as in they didn't feel that way because of the job they had to do. And so he never talked about his war experiences, but he suppressed it. Now, some 40 years later, he's beginning to have nightmares about this. And so some of my colleagues have called this delayed PTSD. What we really think is happening is that as the cognitive decline was beginning, it was eroding his capacity to keep this in the background. Mm. So it was now coming to the fore. So something that he had managed to suppress all these years, he no longer had the capacity to suppress anymore. And so he was now living his PTSD 40 years later.
Oh, interesting.
Yeah.
Has there been research to study the connection between isolation and loneliness to dementia? And if you could talk about isolation, loneliness, and dementia.
Another timely question. I think we're still learning the impact of isolation, but we've had a number of people who have suffered striking cognitive decline in this COVID-19 period, and it's not. And we're not talking about people who had the infection. There have been people who have had the infection, and that's worsened their cognitive situation. But there are people who we know are not affected, but for whom, especially early on in the epidemic, when facilities were still trying to grapple with this, people you couldn't visit, but it was worse than that. You couldn't visit. It was also that even within the facilities, people were kept in their own rooms, so they weren't eating in the common areas. They were basically living in their rooms. And a lot of people withdrew. And one family described to me that mom just gave up and passed, and she passed away during this period. And they really believe that it had to do with the social isolation. I think we're discovering that social isolation, that social interaction might not be far behind oxygen and water in terms of human needs. And it just isn't well understood yet.
Very true. Another question, if you could talk about non-Alzheimer's, is non-Alzheimer's dementia terminal, or do you just suffer and then die from something else, or do you die from Alzheimer's?
So with this exception of vascular dementia, all the dementias are terminal, as in they progress until the person passes. Typically, the cause of death is what we call failure to thrive. So the dementia progresses to a point where they for some reason are not eating anymore. So sometimes it's loss of a swallowing facility, and sometimes it's failure to recognize food and no desire for food. But then that's the point at which they pass. And, it might be facilitated by heart disease, by pneumonias, especially if they have aspirations. But at the heart of it is the idea that there's a failure to thrive.
Well, I'm going to take two more questions. This one is probably many could relate. Does coffee influence neurodegenerative changes?
We don't have any evidence that coffee is a bad thing, and we don't want to see any such evidence. Because we need coffee for work. No, we don't have any evidence that coffee or tea is a problem. Okay. Except to the extent that it might undermine sleep.
And then a lot of people are asking about your practice, where you practice, and it would be helpful if you could share that.
So I'm at Johns Hopkins Hospital. There are Hopkins has two campuses. There are two main campuses. I mean, we have other campuses now, suburban, Sibley, Howard County General. But the traditional campuses are the East Baltimore, Johns Hopkins Hospital, which is there, and then Johns Hopkins Bayview Medical Center. We have a memory and Alzheimer's center that's based at the Johns Hopkins Bayview. And a lot of our clinical research protocols are, especially the clinical trials, are happening at Bayview. I'm at the East Baltimore campus. So the Young-Onset Dementias program, the atypical non-Alzheimer's dementias programs are on the main campus where I am, and that's where I run them. I also have colleagues in neurology who see people with atypical Parkinsonian disorders. So these would be DLB, CBD, PSP. So Alex Panteliets is especially focused on PSP, progressive supranuclear palsy. So we collaborate on some of the research, and he and I and two others have been co-directing our Lewy Body Dementia Center for Excellence.
Excellent. So if someone wanted to get in touch with you, they could Google you. And I have to, I was going to save this for my closing remarks, but I really want to thank you, because I've heard through the grapevine that you have a 6-month wait list to get in to see you. So thank you for taking time today to be with us. I think you provided us with a wealth of information. And for those of you who joined us late, you will be able to catch the recording on our website, and as well as download the slides. So thank you again, Dr. Onyike. And with that, I'm going to turn it back over to my colleague, Lindsay.
So thank you very much. And thank you all for your attention and for your great questions too. I will look in the chat now. And how much longer are you going to keep this open?
We'll be open until just before noon.
Okay, so I will look at the chat and see what other questions I can. I see there's a Q&A. Should I be going to the chat or the questions?
I would look at the Q&A. That's where people are putting
okay,
in
so
their
I'll
questions for you.
Okay, great. So I'll go over there and see what I can tackle.
Another thing we can do for you, Doctor, is we could email you all those questions, and then you could, respond to them at your leisure, and we can send them out to all the attendees.
That would work too.
Okay.
So in the time that's remaining, I will jump on what I can, and then you can send, and we can do both things.
Thanks.
Thank you.
And thank you so much, Dr. Onyike. I learn so much every single time I listen to you. So I really appreciate you taking the time to be here with all of us today, both family caregivers and professionals. So we appreciate you so much.
Thank you. Thank you. Appreciate it too.
And now in our last few minutes together, I'd like to remind everyone that you can visit our virtual exhibit hall to explore some of the local resources in Northern Virginia to assist you in your caregiving and to care for your loved one. So we're going to drop that link in the chat. Feel free to follow that. Also on our website is where you will find the handouts for each day's speakers, as well as the recordings at the end of the day for that day's presentation. And now let's spin for some door prizes. I'd like to welcome my colleague Pat online to help us spin for prizes today.
Hi, who feels lucky and ready to win?
Yes.
Your names on our spinning wheel, and so someone will end up winning the first door prize, which is going to be My Two Elaines, which is the book that we learned about yesterday when Governor Schreiber spoke to us and talked about, and we learned about the love and all the other emotions that went in to his book. And as he cared for his wife from the beginning to now when she's in with Alzheimer's. Denise Adi, thank you.
Congratulations, Denise.
Let's spin for another one of Governor Schreiber's books.
This really is an excellent book. So whether you win one or not, I hope everyone will find an opportunity to read through Governor Schreiber's book.
Donna Poole, got it. Okay.
Yay, Donna.
All right. Now we're going to draw for our next door prize, which is from the program we're going to hear from tomorrow, some of it, from Lindsay's Insight Memory Care Center has a wonderful caregiving guide with tips that are unbelievable. I love that book. So let's spin for the caregiving guide from Insight.
Who's the lucky winner?
That's going to be Marcia Botts. All right, good. Congratulations, Marcia.
Yay, Marcia.
Now, if we can see a picture of a trio of books written by our Friday speaker, Ron Culberson. He's a humorist, so he has a number of books that help you bring humor into your life and of your loved one. So let's see, Steve, let's spin for the trio of books going to one person. Who's that going to be? It's spinning, and it's going to end up with Sarah Murphy. Congratulations.
Yay, Sarah. All right. Thank you so much, Pat. Congratulations to our winners. We will be in touch with you and those books will be mailed to you. We'll be giving away more books each day of our conference. So tune in Thursday and Friday as well. We do want to hear about your experiences today. So we're going to put a poll question up on the screen and we want to hear overall, how would you rate today's session? We will also at the end of the week share a link to a full conference evaluation. But for the time being, we want to hear how was today for you? So there we go. It's up there on the screen. So go ahead and put in your selection. And while everyone is giving us a bit of feedback about today, I'll just share a little preview about what's coming tomorrow. Tomorrow's program is entitled Caregiving at a Glance, Hints, Tips, and Ahas. So that's based on the book that Pat just showed us and that we spun for today. We're going to hear from a panel of experts as they share helpful hints and ahas, and we'll talk about communication tips, safety precautions, activities, routines, how to care for yourself as a caregiver, and more. And we will welcome your questions tomorrow again. So thank you everyone for putting in your votes about today's session. I'm so glad to hear all of the positive feedback. I'm glad that this was meaningful for you. So we'll see you back here tomorrow. It will be day 3. Sorry. Thank you for joining us on day 3. Tomorrow is day 4 of our Caregiver Conference, and we'll see you back here at 10 a.m. So happy Veterans Day. Thanks, everyone.